Good afternoon, everybody, and welcome to the Florida Chapter's Certified Healthcare Financial Professional Series. We're probably going to get started in a minute or two, just to give enough folks. We had quite a few folks sign up, so probably everybody's running from another meeting and trying to jump on here to get their training for certification. So we'll give it just another minute and we'll get started. All right, I think we'll get started. Again, my name is Christine Fontaine. I have the pleasure of serving as the Florida Certification Chair. I've been in healthcare for more years than I want to share, starting as a provider and then moving over to the vendor space some time ago. I have been engaged with the HFMA both at a local and a national level. Serving on quite a few committees, including the Board of Examiners that's responsible for the certification. So really excited to bring these series to you. We have some of our Florida chapter members are nicely joining us to do the CRCR certification. Some of them are joining us today to listen in and assist if needed. And then we're doing, so we, being aggressive here, trying to get more certification for our members, for our region members. And I saw quite a few names on the registration list that are not even close to our region. Some I recognize, so hi to you all that I do know. And happy to share it with anybody that you want. So a couple of housekeeping things as we go through this, and I could get my slide to move. Maybe not. All right, guys, this is what happened the last time. Okay, so the purpose of this program today is to give you an overview of important concepts, right? The in-depth presentation is on the online course. So these materials will be available to you on the Florida HFMA chapter website. These sessions are being recorded and will be available on the Florida YouTube channel. So since it is being recorded, we're going to ask you all to stay off camera for now, stay on mute so that those recordings can be very easily used by other members and you again as you look to practice on here. If you have not already signed up for the CHFP exam, we recommend that you do that. We're going to be putting the link in there into the chat box, but you can find it very easily if you log into the HFMA website. One of the recommendations that my peer John Lloyd from Georgia made was take the exam even before taking the course. Get an understanding of one, what the exam is like, and then two, where are the areas that you need to focus on. You can take the exam again, I believe it's 90 days after, double check that. But that gets us through this online program. And then hopefully you're ready to take it then with some additional studying. Highly recommend that you can sign up for that exam and you follow along as we go through the chapters. So, we cannot, as I just went through the materials again the other day to make sure we're prepped for this, there's so much material out there. There's a lot of types of study sessions and key concepts that they drill you on. So we do highly recommend that you do that along this program and then do a little prep at the end. So more on that. Please put any questions on the chat. If it is technical in nature, we'll certainly try to answer that as we are here. If it is regarding to the materials, then we'll take those at the end. Sorry. And we'll also open it up for questions. Feel free to join your peers and get on camera and ask your questions appropriately. So one of the things I also want to make sure is this. We are training to the online material. And there may be a time, and we've had it in the past, where individuals felt that the answer as recorded by HFMA wasn't correct. And if that's the scenario, then we are happy to take that back and bring that back to HFMA so that we can challenge the answer to a question. So we are happy to work with you on that as well. So, and off we go. Next to national defense, the healthcare industry in the United States is one of the largest sectors of the economy. I think we all know that. It currently makes up almost 20% of the nation's GDP. Healthcare in the US will be a significant factor in the national economy for the foreseeable future. So upon completing this course, you should be able to identify the current trends of the healthcare delivery model, determine the future methods of payment for healthcare services, identify the impact of healthcare reform on the healthcare systems, and then define the role of health financial management in healthcare organizations. Now, healthcare in the US is not a simple relationship between a sick or injured person, usually referred to as a patient, and a party rendering medical care, such as a physician or a hospital, either often referred to by the term provider. There are a multitude of different participants in the delivery of medical care, most of which are not directly involved with treating an illness or injury, and include insurers, regulators, and suppliers. So a myriad of general relationships in the delivery of healthcare services in the US is illustrated here. The orange arrow illustrates legislative or regulatory influences, which we know there are a lot. The green arrow illustrates common flows of money, and the blue arrow illustrates flows of goods or services. So it can be somewhat complex. There are several different types of healthcare providers involved in treating the sick or injured, representing different disciplines. The broadest classification is between facility and professional providers. Facilities usually deemed as hospital, skilled nursing, assisted living, home health, ambulatory surgery centers. Our professional providers are typically physicians, pharmacists, nurses, allied professional providers, PT, CSWs. The specialties of radiology, anesthesiology, pathology, along with emergency room physicians and hospitals, are commonly referred to as hospital-based physician, since the majority of their work, not all of it, but the majority of their work is done within a hospital facility. Other physician specialties may also provide care within a facility provider, such as when a surgeon operates on a patient in an ambulatory care center or when an OB/GYN delivers a baby in the hospital. While hospitalists are hospital-based physicians, hospitalists and hospital-based physicians are not synonyms. Hospital medicine is a medical specialty dedicated to the delivery of comprehensive medical care to hospitalized patients. So many of us probably know long time ago, your actual PCP would come in and do their rounds in the organizations. That's very, very rare right now. You're being treated by hospitalists and intensivists if you're in an ICU. So one complicating issue in today's healthcare system is that the fact that each provider rendering care to a patient can typically bill for services related to the patient. So for example, if the patient has a surgery to repair a hip injury in a hospital, then fees can be billed by each of the providers participating in that care. including the surgeon, possibly the hospitalist, possibly radiologists, and things like that need to get done. And that's where it becomes very confusing for our patients. In the healthcare system, the relationship normally is seen between a buyer and seller of goods as services. It's not like the purchase of an appliance or home cleaning services. So it's unlike many other sectors of the US economy. In healthcare, the patient is the consumer of services, and the provider of services is a physician or pharmacy, facility or other provider, and a third-party payer, such as a government or commercial health insurance plan, pays for the services. As illustrated later in this course, and again in course 5, Managing Financial Resources, this can introduce some complication into how healthcare physicians, hospitals, and other healthcare providers operate their businesses. So as you can see, the 3 largest third-party payers by annual expenditures are private health insurance, certainly added up when we add the ACA in there, Medicare, and then Medicaid. So first polling question, which group of words below represents those not directly involved in patient care? Insurers, providers, regulators, suppliers, insurers, providers, and suppliers, insurers, regulators, and suppliers. I have a good feeling about this group. You're all going to get it right. Okay, Diane. There you go. I knew that was going to be a smart group. Insurers, regulators, and suppliers are pivotal in the business environment in which care is provided. None of these entities provide medical treatment to patients. Another polling question. Keep you on your toes here. Which of the following is not true regarding fees provided for services? Not true. So keep in mind, HFMA does do that. There can be multiple providers involved in treatment to which fees are owed. There is often a third-party payer which pays for services. There is always only one provider to which fees are paid. Okay. And there you go. Okay. So the reason why it is common for several different types of providers to be involved in treatment and consequently are due fees. There is not always a third-party payer which pays for services. I can see where it says there's often a third-party payer, and that could be true. Per HFMA, the correct answer is 3. So healthcare payment is unique in that less than 11% of the 3.5 trillion the US spent on healthcare in 2017 was paid directly by the recipients. The rest was paid by someone else. The revenue cycle in healthcare can be described as the flow of money between the patients, the insurer, and the provider of healthcare services. Depending on the type of insurance a patient has, or if they have no insurance at all, the employer that provides insurance to the patient may also have a part in that description. If we think about self-funded plans that are at financial risk until they get to their stop loss, that would be a good example where an employer is engaged in the decision-making. So a third party makes the payment on behalf of the consumer, usually with some rigor around it to ensure it's being paid appropriately to the supplier of services. And then this third party creates some extra work in healthcare that we may not see in other consumer industries. So the administrative burden to get paid, which is why many of us have jobs in the healthcare industry today and deal with that day-to-day challenge of trying to get paid. So let's start with illustrating the most basic relationship, that between just the patient and the hospital or physician the provider services them. This diagram simply illustrates the two-party relationship when the patient either has no insurance or the insurance does not cover the services sought by that patient, not medically necessary, not a covered entity. While many providers offer discounts to uninsured or uninsured patients for emergent and urgent care, and certainly have charity care programs, presumptive charity, tiered charity responses, right? It's what we're trying to do right for our patients. Providers typically charge full services for services that may not be considered medically necessary, such as cosmetic surgery. Prior to passage of the Patient Protection and Affordable Care Act, commonly known as ACA, that insurance was usually provided by an employer to the employee as an additional form of compensation, known as an employee benefit. Since passage of the ACA, it is common for some patients to obtain insurance directly from an insurer through the exchanges when the patient does not get health insurance as an employee benefit. As a result of the ACA, more than 90% of the patients in the US now have health insurance. Employer-provided health insurance is still the dominant form of insurance. Whenever the patient obtains health insurance, either through an individual plan or employer-sponsored plan, insurers often require some out-of-pocket payments by the patient to go along with the insurance payment, usually as an incentive to the patient to use insurance only when needed. As I said, I've been in the healthcare industry for a very long time, and when I was originally employed, we had minimal out-of-pocket costs per paycheck. We had minimal deductibles. We had minimal co-insurance. I think we all know that is no longer the case today. So it includes deductibles, a lot of times high deductible health plans where some patients may never actually have insurance pay. And that is a predetermined amount that the patient pays before the insurer begins to pay for certain services. Co-insurance is a percentage of the insurance payment amount, the allowed amount that is paid by the patient, along with the amount paid by the insurance. And a co-payment is a flat amount that the patient pays at each time of service, typically seen in emergency room settings, office settings, etc. So this illustration describes, and you could see it's somewhat complex, the normal flow of funds and services for a patient that has insurance provided by their employer. A situation that applies again for about 140 million persons of ages less than 65, or about half of all persons working in the US. So the flow of services is indicated with a red arrow. Payments are represented with a green arrow, and the flow of information is presented with blue arrows. So step one, the patient pays a premium to the insurer. Step two, the patient then seeks services from a provider and pays their out-of-pocket costs, if you're lucky. The provider sends a claim for payment to the insurer for services rendered. The insurer evaluates the claim to ensure services are covered and necessary, may request additional information, may deny the claim if there's inaccuracies on it. You've got administrative burden there. The provider then may have to provide additional documentation, may appeal any denials before getting paid. And this process here is what drives up the administrative costs within the healthcare system. And what we're trying to do as an industry is to simplify this so it is not burdensome on all of us. So Medicare Part A is funded primarily by Medicare taxes paid by current workers to fund the cost of current beneficiaries, covered if they are over 65, disabled, or have ESRD, end-stage renal disease, and have paid Medicare wage taxes for at least 40 calendar quarters. Medicare covers, Part A covers inpatient hospital services, certain organ transplants, ESRD treatment, inpatient skilled nursing facility care, home health care, and hospice care. Part B is a voluntary program where a patient that meets the age or medical condition requirements may participate in this insurance benefit. It is possible for a patient to be covered by Medicare Part B, but not A, and conversely, Part A, but not Part B. Part B is funded by a combination of premiums paid by the patient and general tax revenues. It covers physician services, outpatient hospital services, outpatient diagnostic services, therapy services, outpatient mental health. Part C, Medicare beneficiaries can receive Medicare benefits through a private health insurance plan, such as an HMO or a PPO. Medicare Part C is also referred to as the Medicare Advantage program. A private health plan provides an alternative for patients that do not wish to receive services through traditional Medicare Part A or Part B. Usually these Medicare advantages are much more restrictive and have narrower networks for a patient to choose from to get the full benefit covered. Medicare Part D is the newest Medicare program implemented by CMS. It's been around some time though. The Part D program covers outpatient prescription medicines for persons otherwise eligible for Medicare benefits. Similar to the Medicare Advantage program, Part D is administered through private health insurers that provide prescription drug benefit management through private retail pharmacies across the US. So the federal government, through the Centers for Medicare and Medicaid Services, or CMS, oversees all of the Medicare program. CMS receives Medicare payroll taxes from workers along with Part B premiums from patients and adds these funds to the Medicare Trust Fund. The Medicare Trust Fund is the overall pool of money used to finance the Medicare program. However, CMS relies on organizations in various regions around the US to administer payments on behalf of Medicare beneficiaries. Organizations acting on behalf of CMS to administer Medicare payments are known as fiscal intermediaries, or FIs. Medicaid and the Children's Health Insurance Program, or CHIP, provide health insurance for low-income Americans, people with disabilities, pregnant mothers, and eligible children. So just being low income does not qualify you for Medicaid. You have to have the other qualifying conditions to be able to actually be eligible. Medicaid and CHIP are administered as joint programs between the federal government, CMS, and the individual states, with CMS picking up about half the costs. Medicaid is the third largest domestic program in the federal budget after Social Security and Medicare, and Medicaid is often the largest program in a state budget. Again, they have to meet qualifying factors, like I said: disabled, pregnant mothers, eligible children, mothers with dependent children, and elderly. It currently serves over 74 million Americans. It must include things like hospitalization, outpatient care, physician services, family planning, obstetric care, home health, and transportation services. For anybody that has worked in the physician provider space, because Medicaid often makes up the largest component of the state budget, you are aware that the rates offered are usually lower and sometimes even lower than the cost of care for many organizations, and it may limit the number of participating providers. So each state has its own Medicaid program that is financially, but partially through what tax revenues paid to each state, and again, a contribution from CMS. Some states do require co-payments for visits, which is I always find interesting, and some require a spend down of income above the federal poverty level amount to qualify, meaning the patient has to pay X dollars, sometimes in the thousands, out of their own funds before Medicaid will kick in. Again, not Medicaid co-payments and spend downs are not easy for providers. An important element in how much an insurer will pay a provider on behalf of a patient is the patient's choice of provider. In response to the rapid escalation of healthcare costs in the US, health insurance have sought discounts on fees by creating provider networks with preferred or in-network providers. Under this relationship, the insurer will pay a higher proportion of the patient's cost of care in exchange for the patient going to the in-network provider. Under many insurance plans, patients may seek care from other providers outside of the insured network, but the insurer would pay a lesser amount and leave the patient responsible for a larger amount for their care. As we know, surprise billing legislation is out there. Everybody's talking about it. So what that's going to mean for organizations, how difficult and what it means for patients, certainly more to come for that as we navigate those challenges and possibly get a reprieve for a little bit. So next polling question. Which of the following statements describes how healthcare can be financed? Patient pays fees directly to the provider. Patient pays premiums for individual insurance. The insurer then pays the provider. Patient has employer-provided insurance, all of the above. Okay, I think you all got this one right. All the above, very good. I'm reading the question going, well, one's right. Oh, that's right, it's number 4. So, okay. Oh, another one. Two for one. Which of the following statements is true regarding Medicare? Medicare provides insurance to the poor and medically needy. Medicare provides insurance to people over 65, persons with disability, and persons with end-stage renal. Medicare provides insurance to people over 65 and older, and then all of the above. Okay, we'll close that up in the interest of time. The correct answer is number 2. It's not all of the above. Medicare has nothing to do with the poor and medically needy. That's the Medicaid program. Medicare provides insurance to people over 65 and older. That is accurate. However, you need to address the fact that people with disabilities may be under 65. Certainly people with end-stage renal disease may not be over 65. So it is number 2. Oh, did I do 3 in a row, Diane? Oh my gosh. Which of the following is not true regarding provider networks? Insurers pay a higher portion of the patient's cost in exchange for the patient using providers within the network. There is a perception among patients the networks do not provide a high level of quality care. Provider networks were established by insurers to seek discounts on fees. And even in emergency situations, the patient must use an in-network provider to receive the highest benefit. And again, which is not true regarding provider networks. Okay, we'll bring it up. The correct answer is number 4. In a true emergency, patients may seek services with an appropriate provider and still receive agreed upon benefits. This provision does not apply in the case of a medical emergency. In such cases, the patient may seek care at the nearest appropriate provider. Okay, moving on. Okay. So prior to the implementation of quality programs by commercial insurers and government programs, providers could get paid for treating both a patient's original condition and, in addition, an avoidable complication that occurred while the patient was in the hospital. For example, if a patient were hospitalized for treatment of pneumonia and fell while in the hospital, suffering a fractured hip, the hospital could get paid for treating both the pneumonia and the hip fracture. This is no longer the case. Hospitals now face a list of undesirable situations or conditions known as hospital-acquired conditions, or HACs, which include injuries or infections incurred while the patient is hospitalized. Services to treat such conditions will not be paid by Medicare and most commercial insurers. A medical condition on the HIC list is considered to be hospital-acquired if it is not shown as present on admission on the claim. And for those of you that had to deal with conditions and all of that stuff when we had to get them on our claim forms, that was not fun. Medicare's Hospital Readmission Reduction Program, or HRRP, affects more than 3,000 hospitals across the country. This program reduced payment for all discharges, not just the readmission. Given the relative size of the healthcare industry in the United States economy, healthcare has grown to the extent that there are concerns about healthcare taking resources away from other parts of the US economy, which makes sense. Recall that some people in the United States obtain health insurance as a benefit of employment. However, the cost of healthcare insurance increases the expenses for employers, which leads to increased prices for consumer goods and services. Similarly, increased cost of government insurance programs creates pressure on legislators to reduce funding to non-healthcare programs or increase taxes. Generally, there is some concern that the volume of expenditures for healthcare services in the US is not sustainable over the long term. Therefore, there is some pressure, and has been for some time, on legislators in the US to reform the healthcare system. The definition of reform in the context of healthcare could take many forms. Some consider it to be a complete change to the national healthcare system, or the consolidation of health insurance plans into a single government insurance plan, or a change in the way that health insurance is marketed to consumers, such as the use of a health insurance exchange like those in Germany or Switzerland, where all consumers have access to a panel of approved commercial insurance plans. Certainly, on the side of those folks that don't agree with those, it's the cost to it. Who's going to actually pay for those programs, and is it something that is sustainable? All right, and why is this such a big issue? These are 2019 numbers. We spent $3.58 trillion on healthcare, many of that at end of life, and growing, right? And it continues to grow, $11,000 per person. 17.7% of the GDP, and growing at a rate of 4.6%. As I mentioned, most expenses occur in the first 10 days of life, makes sense, and the last 10 days of life. I'm sorry, that should say life. And then certainly, you know, we need to get some type of control over this, which is what the healthcare is trying to do. Much of the reform ultimately was aimed at reforming health insurance markets, where major changes were applied to the way that health insurance operated, with some changes to influence more persons to get access to health insurance coverage. As we all know, the individual mandate was taken out, whether it got put back in or not, we don't know, but that component of the mandate was removed. And then key provisions of ACA. So insurance plans were required to spend a minimum amount of collected revenues to pay for medical care of patients, called the medical loss ratio. More controversial changes implemented by ACA were around the overall insurance marketplace. The individual mandate, which is no longer in play, was a change to require individuals without employer-provided insurance to purchase health insurance through health exchanges in each state, or face tax penalties, which the penalties were typically not enough to get people to buy into it. The employer mandate is a provision where employers with more than 50 employees to make health insurance benefits available to employees. Certainly that was a burden on many small employers. It also called for structural changes in the delivery of healthcare services. Accountable care organizations, or ACOs, are an opportunity for various providers of care to work together to manage the healthcare of a select population of patients and to receive financial benefit from reduce the cost of care, but still improving the quality of care for those patients. And that's called population health. And related to the ACO is the addition of bundled payments to the group of providers for a single occasion of service to a specified patient. So no more of the everybody bills the patient component of it. It's a bundled payment to one organization, and that is structured across all of the providers in that care. More on the bundled payment mechanism will be found in course 5 when we get to that in managing financial resources. So one of the major changes to management in the healthcare industry has been the shift of emphasis from the volume of services to demonstrating the value for payments. Since value-based payments places payments at risk of loss, and the amount of potential loss could reduce or erase the income earned by a provider, greater emphasis is being placed on achieving the quality and patient satisfaction goals as a means of maintaining financial performance. To increase healthcare value, you need to improve quality and reduce costs. The tactics used are creating things like value-based purchasing, reduce preventable readmissions, reduce hospital-acquired conditions, bundled payments, and again, accountable care organization. The prerequisite is to have electronic health records to be able to do that. We can't get there without electronic health records that are across the continuum of care. Okay, another polling question. This is an easy one. The individual and employer mandates were established by the ACA to increase the number of insured, thereby increasing the cost of healthcare. True or false? Okay, let's close that up. You only had 2 chances. It's actually false. The mandates were established to increase the number of insured in order to spread the cost among more people, which would hopefully lower the prices consumers pay for health insurance. So moving on. Oh God, I did it again. Here goes another polling question. Which of the following terms is not a part of the ACA reforms? Medical loss ratio, pre-existing conditions, non-rescission, spend down. I feel like I should be playing the Jeopardy music in the background while we do this. Okay, let's close it up in the interest of time. Correct answer is actually spend down. Spend down refers to the option to use up any existing asset or income to become poor enough to meet Medicaid eligibility. This was not addressed in the Affordable Care Act, but is a part of the Medicaid program. So this is a good reason why you can't just do the course, right? As I mentioned, a lot of these materials, these are questions that are coming right off of the online exam. And we probably did not go over non-recession as part of it, but it is included. But that will be in the other materials. So I can't go through all of the materials in the time that we have allowed. We're coming, close to it anyway. I got to go a little bit faster, but just wanted to point that out. These are the types of questions you'll have. The other material will support that. Oh, I did it again. The ACA has created the necessity of competition between which of the following? Healthcare providers and consumers, healthcare providers with each other, insurers and healthcare providers, insurance and consumer. Again, the ACA has created the necessity of competition between which of the following? Okay, close it up, Diane, please. Healthcare providers with each other. Providers compete for consumers by choices by competing on value, cost, and quality outcomes. So if I have a good cost and quality outcome when I work for University of Maryland, I'll use that, then I'm likely to go back to them again. If I did not, I may choose to go somewhere else. So that's really where they're competing with each other. Again, in the Baltimore area, we probably have about, don't joke, it feels like we have 500 healthcare providers all within walking distance of each other. And they're competing with each other. And cost and quality outcomes will absolutely drive that decision on where a patient goes. So we're going to walk through the role of financial management in healthcare organizations. And we're going to talk about how the role of the finance organization has changed dramatically since we got into cost and quality. The finance function in many healthcare organizations is carried out under the direction of the CFO, Chief Financial Officer. This is true in most hospitals, health plans, and larger physician clinic entities. Some organizations may use the term controller to define the senior financial manager. Larger entities may have both a CFO as the senior leader in finance, with a controller reporting to the CFO. Usually the finance function reports directly to the CEO of the business or to the owner in a smaller clinic setting. Financial management in a healthcare organization usually entails activities including accounting, bookkeeping, treasury, inventory, budgeting, payroll, accounts payable, financial analysis, revenue cycle. Further details on inventory and the revenue. Health insurance plans will usually include claim processing and contract management activities under the finance function. Since it has much access to much of the data needed to manage costs and can access clinical data through its financial analysis activities, the finance function has adopted a much more strategic role in today's healthcare business. Historically, finance has had much of a record-keeping function through accounting for business transactions. However, access to and understanding historical data has placed finance now in a leadership role to aid in setting the future direction of the healthcare business. However, with that broader strategic perspective, the challenges to the healthcare CFO are both diverse and difficult to balance. Not a job I would want. So, and as you can see, current pressing issues, right? As the value-based purchasing provisions of PPACA have taken effect, and some providers have seen reductions in payments for services, the impact of quality on payments has become critical. At the same time that value is a priority in the healthcare industry, there is a significant upward inflationary pressure on expenses, particularly in healthcare provider entities. Healthcare technology is also exerting significant upward pressure on the operating expenses in the industry. While technological innovation in some areas such as computer or consumer electronics usually yields reductions in price to the buyer, such is not the case in healthcare. As new technologies enter healthcare, they generally cost more than in a prior iteration. The demand for technology brings with it the need for resources to pay for it. As pressures for lower costs limit growth on payments to healthcare providers, their ability to finance new technology can be greatly hindered. Not only that, but the priorities on what technologies to obtain are changing as emphasis on outcomes and cost increase on healthcare businesses. The advent of the ACO introduces the element of risk contracting to a healthcare provider entity. Health insurance plans manage risk continually, and so this is less of an issue in such businesses. The ACO places hospitals and physicians at some risk of financial loss if the cost of care to patients exceeds target levels set by insureds that contract with an ACO. So which of the following activities does not occur in the financial department itself? Ordering supplies, accounts payable, accounting bookkeeping, and payroll. In the interest of time, we'll close that up, Diane, please. Ordering supplies, good job. Payroll is definitely within finance function. So the ordering finance providers need fiscal resources for ordering supplies, but does not directly place the orders for the supplies. That's usually in a different department. Oh, okay. Select the formula that reflects the value proposition. Quality is equal to value divided by payment. Value is divided by payment versus quality, and value is divided by quality over payment. And we'll close that up. Actually, value is defined as quality patient outcomes, patient satisfaction, safety, and cost, versus payment is the amount paid by all purchases of care. So it's value over payment. Next slide. Diane, remind me not to do 3 polling questions in the future. Which of the situations listed below does not put inflationary pressure on expenses in the healthcare industry? Again, does not put inflationary pressures. Increased patient volume, salaries of healthcare specialty providers, healthcare technology, risk contracting. Okay, close that up. Increased patient volume does not cost inflationary pressure. However, expense costs will increase as more resources are utilized. So the correct answer is number 1, increased patient volume. Okay. And I think we're actually at the end of our slides. And so Diane, are anyone that's monitoring the chat, any questions in the chat? Or does any of the open it up? We've got time to do so.
Christine, can I ask a quick question?
Absolutely, you may, Colby.
I was just going to ask, so there was a link provided in Diane's stuff to the exam, but you mentioned the additional reading that supports the stuff that you're discussing today. Where do we go to get to that?
So when you sign up for the certification itself on the HFMA link, it's actually going to provide you with the online materials. So you'll actually have it in your e-learning on when you go in to sign on, you'll see an e-learning thing. So once you register and sign in, then you'll have access to that. It will tell you how long you have access to it. Read through the resources. I really can't recall off my top of my head, again, the amount of time between tests. Honestly, if you just go take that test, as again, my peer John Lloyd in Georgia recommended, and I think it's a great idea, take the test to get an idea as you're going through the training. And then I think it's again a 90-day window, but it'll tell you that on the website. I just can't remember off the top of my head. As you go through your training, you'll have a better idea, again, what is the test like and where do I need to spend my resources? For me, I've been in revenue cycle my entire career. The finance areas, the different statistics and the different formulas is where I really had to focus my time and my energy, because I just didn't know that as well as what I lived into a day to day. So you'll probably find that when you go through the exam, you'll get most of it right.
Very good, thank you.
You're welcome. Other questions? Well, again, thank you for all of your time. Is there a question? Yeah.
Yes, sorry, I couldn't figure out how to get my mute button off. It wouldn't cooperate. This is Candy Powers.
Hi, Candy. How are you?
I'm good. How are you? I haven't seen you in a really long time.
You got it.
First of all, thanks for doing this. Secondly, just a quick question about the exam itself. I know it's gone through many iterations in the 8 years that I've been running from taking this exam. I'm going to do it this time, but Do you know, is the test still open book? I know there for a while it was an open book test, so you could take notes and then you could reference your notes while taking the exam. Do you know if that's still the case?
It is the case because you're doing it all virtual. So yes, in reality, you could do that. So you're going to take notes. You want to write down any materials. You can have these materials, refer to them, write on them as you're going through the sessions. That may be helpful as well. But as I said, I can't go through it all in 45 minutes. There's no way we could go through each one. But in the same context, I'll tell you that if you don't study and you're only going to try to pass the exam by referring to notes, probably
no.
Yeah.
No, that's not the implication. Just
Yeah.
For those of us, like I said, who've been running from the test for a long time, that is just an extra little added security blanket.
Yeah, I don't think that's a problem at all. I would think that, but I didn't want anybody else to come away. I knew you wouldn't get anybody. I didn't want anybody else to come away to think that it's, note taking is going to ever get you through this. It's a bear of an exam to pass. So I'm not going to lie to you. I studied significantly for this exam, and this is years ago. And that's when it was not really, I don't think it was open book when I took it, because we had to go sit in a room. I was in MedStar in Baltimore with people looking at me, and we had to take it online, like there. So, being done virtual, certainly you have options to, and I don't think HFMA is going to care if you're looking at notes or not. Okay. Any other questions, either about the materials, thoughts on the training? Hopefully this is helpful to you all. And get you motivated to take it, or anything about the exam at all.
I have a question. I think this was very helpful because I've already started reading all the materials for weeks and weeks on this training.
Okay.
It's very overwhelming, but can you just go over where this registration link is? I joined a few minutes late. I apologize, but I'm not sure if you covered that.
Yeah, let me see if I can end my slideshow and get over to HFMA real quick. Or you should still be seeing me. Sign in.
And Christine, I did put the link at the beginning of the chat.
Awesome.
Yep.
Hey, are you still seeing me? It's showing my screen sharing is paused. Can y'all see the HFMA website? Okay.
No, I just see your PowerPoint.
Stop share real quick. Again, sorry. Okay, seeing it now?
Yes.
Okay, cool. So when you sign on to the website, you will see the education and events over here. You want to go to certification. And then when you come down, you'll see CHFP over here, CRCR over here. So you would just learn more and then register that for that at that point in time. It should just be a little link down here. Usually there is some. Oh, you know why? I'm going to tell you why. Because I already have it in my e-learning box. So you should see something to register. To access it, you're going to click on that e-learning and you're going to go to your dashboard. Pretty sure that's how I'm doing it. And you could see what you have available to take in the exam.
Okay. Thank you.
You're welcome. So these are the ones that I've started. And I think my CHFP is in there. So it's somewhere in here. Okay. Other questions?
Is the exam timed?
Yes. I can't recall the time. When you sign up, it will tell you exactly. It has all the stuff about how long you have to wait to take it, how long, how many, what the timing is, etc. So yes, it will be a timed exam.
So you said
Christine, this is Adam.
Oh, go ahead.
No, go ahead. I just wondered if it was proctored.
It's not proctored, it's online.
Did you say it is virtually proctored or not?
It's not, it's to the best of my knowledge, it is not virtually proctored.
Thank you.
You're welcome. I'll double check on that one though, because I haven't taken it personally myself. I just took the CRCR and that was not virtually proctored. But I'll check with National and get an answer to everybody on that one. I don't believe it is.
Can the e-learning be done on a like an iPad or anything, or does it need to be done on a computer?
I would think as long as it has the same functions to move screens and answer questions, because you're going to be moving into the next section, they'll have some things for you to like, take this take this word and put it with its definition. It's got a couple of things where it's going to have to calculate what is the patient's cost based on deductible, out of networks, Medicare coverage. So there's some calculations and work there, activities. So as long as you can do that on an iPad, then I don't see any reason why you couldn't do it there.
Okay, I'll be traveling next week, and I was thinking that would be a good time while I'm sitting around to try to do some of that.
Yeah, hopefully it does. Let us know if it works.
All right, thank you.
Other questions? Okay. Well, if anybody has any questions, most of you should have my email, so please feel free to reach out. If anybody has recommendations on how best to provide this to our members, our chapter members, and many from like West Virginia. So welcome, Candy. Please feel free to share the CRCR certification series with your staff that might be members but not certified, particularly if you are an enterprise member where certification and membership is available for your team. Great way to get those certified and meet those career ladder goals. And then certainly CHFP, please share this with anybody that you know has been putting it off, that this may help them, take the leap and take it. So feel free to share. We're more the merrier. Okay. And with that, we thank you for the time, and I hope you have a great day and great weekend, and see many of you next week.
Thank you.
Thank you, guys. Take care.
Thank you.
Thank you.